If you're older and rely on the compassionate care of others, then 2020 has likely been a year of intense deprivation and heartbreaking isolation. If you're a woman of color, and if you are a healthcare worker or an essential service provider, or if you're a gig worker, then 2020 has likely been a year of tremendous stress and financial struggle. Those two stories, that of the elderly and that of the worker, are interlinked. It's that interdependence that I'd like you to keep in mind for a moment as we play a short video that was supported by SEIU, CUPE, and Unifor, an advocacy video that we call Care Not Profits. Thank you. So obviously this video is a raw reminder of the teachings of elder care expert Pat Armstrong, who said, "The conditions of work become the conditions of care." So put yourself in the shoes of the workers, who are predominantly women. They're overwhelmingly low paid and overworked. You witness the seniors that you love and that you form bonds with die in overcrowded conditions. And those seniors saw you work while wearing garbage bags. I can tell you of countless of nurses, personal support workers, and other essential healthcare workers who have feared for their lives over the past 10 months and the lives of their families. All of us can share stories with you about frontline workers who had to live in trailers. I had one that lived in his backyard shed so that he wouldn't bring the virus home to his family. They all experienced a roller coaster where you started the year with possibly 2, 3, or 4 jobs, trying to seam together one full-time job with full-time wages. And then a few weeks go by and suddenly a mysterious virus is making the news. Another few weeks pass and seniors in our long-term cares become ill. You're told that you cannot wear masks because masks will scare the residents. And we are following all the guidelines given to us by the government, the chief medical officer, and public health. And by the way, all of those guidelines prove to contradict each other. Then another couple weeks pass, and you're still without the personal protective equipment you need to stay safe. But now seniors are dying, and you're made to place those elderly who you know and love into body bags because funeral homes wouldn't come into your nursing home. You received ration masks and gowns and were told to wear them for a full shift. Then the government rips away your financial security by forcing you to work in only one job. Even though your rent is the same, your bills are the same, the needs of your growing kids are the same. Your unions, all of us, continue to lobby the government to keep you whole and arguing constantly for the personal protective equipment you so desperately needed. You can't get any answers from your boss. The premier tells you he has all the PPE we need. Just call his office and he will seemingly deliver it. And then the Canadian Armed Forces issue a report that falls on the public like a ton of bricks and makes you wonder, why did my voice not count the thousands of times before when we sounded the alarms? The only people surprised out of that report was the Premier and the Ministers of Health and Long-Term Care. None of us who work in long-term care were surprised by that report. By now, over 1,800 vulnerable seniors have died from COVID-19, and thousands of healthcare workers have contracted the virus themselves, too many of whom have also died. In our union, The 3 members we lost to COVID-19 were all personal support workers, all women and all women of color. I know that CUPE, Unifor, and ONA also lost members. I remember one of those women's children telling me, crying on the phone, about how they begged their mother not to go to work without the proper personal protective equipment. And her response was, my seniors need me, my coworkers need me. She died, and while we were having the funeral for her, her husband had contracted it from her and was in the hospital, and her kids couldn't see him while their mother was being buried. No one should go to work fearful of dying or coming home and infecting their families. This was not a coincidence. It was a consequence of a system that was reckless with the lives of these dedicated workers, predominantly women. If I can again ask our tech support to now display the photo of the members at work.
Can you guys see it?
We share this illustration of healthcare workers in garbage bags because staff were forced to go to social media with pictures like that to expose their own vulnerabilities and fears. That photo was a cry for help. And after that photo did hit social media, a doctor and people in the community began sewing personal protective equipment for that home. SEIU was able to obtain some N95 masks and surgical masks, and we were told by their bargaining agent to stop delivering them, if you can imagine. So imagine these employees of Chartwell there in those garbage bags, a corporate-run, for-profit, publicly traded with a market cap of over $2 billion. And employees were forced to wear garbage bags over their gowns in an effort to extend the life of their rationed PPE equipment. A recent High study revealed that in Canada, we have as few as half as many staff per 100 residents in our nursing homes as other countries that better responded to the pandemic and had a much better outcome. Staffing levels matter. And we also know that for-profit nursing home chains have 17% fewer staff than nonprofit run facilities. It's also a fact that the worst performing nursing homes with the largest number of outbreaks and the most deaths are overwhelmingly concentrated in for-profit facilities. Over the past decade, the big nursing home corporations, including Chartwell, Extendicare, and Sienna, have paid out over $1.5 billion to corporate shareholders in the form of dividends. In the first 6 months of this year alone, as workers died and residents died, the same big nursing home chains paid out an additional $160 million while the pandemic was going on in our country. They had the cash, lots of it, but continued with a business model that prioritizes shareholders over seniors.
Yep.
Our system has failed to hold any operational decision maker accountable in any real way. Just this week, the Conservatives voted down a motion brought forward by the NDP to phase out for-profit senior care. By contrast, in October of 2014, the Obama Justice Department fined Extendicare $38 million for, and I quote, materially substandard nursing services that were so deficient they were effectively worthless. Extendicare then left the United States, and we know they continue to operate in Canada without ever being held accountable for a business model that exploits women and leaves seniors without the care they need. To be clear, Canada's biggest nursing home chains are not in the business of delivering care to our most vulnerable. They are in the business of acquiring real estate assets for their shareholders. Now we are facing the second wave. Nowhere ready for what is predicted to be an even worse outcome than the first. With the weight on their shoulders, you can begin to understand why some frontline workers are leaving the long-term care sector. The physical, mental, and financial challenges are simply too great, while the consequences for failed government and industry decisions are quite obviously too little. In a recent survey of our members, 68% indicate their take-home pay is less today than it was in January, even after the temporary wage enhancement announced recently. Among recent challenges remains some hope, and that's because of people like Michael, Katha, Tim, and Jane, and all of you who have their back. It's the 50,000 people who added their name to the Care Not Profits petition calling on Doug Ford to fix the system and finally end the failed experiment of for-profit care in Ontario. It's the many bills being introduced to improve long-term care conditions and organizations like the Ontario Health Coalition that will help change what needs to be changed. So if you haven't done so yet, please do. Go to www.carenotprofits.ca to add your name, and let's reform the system once and for all. Call your MPP and demand they raise standards, hold owners accountable, and end the exploitation of long-term care workers in our province. Thank you very much. I'll pass it back to you, Jim.
Thank you very much, Sharleen, for that. Folks, if I could ask that anybody who hasn't muted, if you could do that now, just so we can make sure that we hear the speakers. And I'm now going to introduce our next speaker, who is Katha Fortier. She is the assistant to the president of Unifor and is a passionate advocate for and activist for public health care. She has relentlessly pushed for improvements for staffing in long-term care. She herself is a trained RPN. She has led her union's healthcare sector and is a longtime friend of the Ontario Health Coalition. Thank you, Katha, for your great work. You should be unmuted. And if you aren't, I'm sure Megan will help you. And please start.
Thanks. Can you hear me all right? All right. Nice to see everybody, and thank you for inviting me. I really, Sharleen outlined the challenges in long-term care in the first wave of the pandemic, and we can see that starting again with the second wave. But thanks to a lot of work, essentially by unions, we will be in a little bit better position, at least in protecting our members, the frontline workers. So I don't think, it's a surprise to anybody that long-term care homes were hardest hit during the first wave. The reality is that they were the least prepared. Hospitals were certainly in better positions. They had pandemic plans. They had infection control specialists. They had experts. Long-term care homes, particularly for-profit homes, were not equipped with any of those things during the first wave. And I can tell you that probably like any of the unions on this call, we spent the first several weeks on conference calls, on Zoom calls, our own leadership. We would have regular calls with our membership. We have about 15,000 members in long-term care and another 10,000 members in hospitals in Ontario, as well as a number of workers in social services and various agencies that were in very high risk. And we spent probably twice weekly on conference calls with those groups, with all of our leadership, with our health and safety people on the calls, with our oftentimes our lawyers on the calls, because quite frankly, there was real challenges. And as we saw some of those nursing homes hit code red outbreaks, we saw really different responses across the province. And you would just imagine fielding calls where it's 3 o'clock on a Sunday and a personal support worker messages you, texts you and says, there's me and one RPN on the floor for 60 residents right now. And, you just don't know, you don't know the devastation. I mean, as Sharleen talked about the workers and our workers getting sick and dying, we had one member that passed away as well from COVID, worked in an assisted living home, and essentially the PPE were locked up. Once COVID, mid-March, they locked up their PPE. Nobody had access, even the PPE that they would have had if they were caring for somebody that had pink eye or, had the flu. Everything was under lock and key. And we found out afterwards that he was buying masks from the dollar store. So there was such devastation and such lack of PPE at the initial stages. And in nursing homes, almost always invariably we heard that N95 masks were under lock and key. So this was a huge challenge. We saw the ministries struggle. We saw the premier on a daily basis, as Sharleen said, tell you, call my office if you need PPE. But I can tell you, it was not that simple for our members. And not only, we had members working in garbage bags, but lots of faulty substandard PPE, gowns that didn't close properly, face shields that only covered the offer any side protection. And it certainly wasn't a surprise to us that personal support workers who gave the most intimate care in these settings were contracting COVID at the highest rates. Shamefully, the ministry didn't even start collecting data on personal support workers collecting PPE as a separate classification until the end of May. So we don't even know the real data except from what we have from WSIB. Now, it was interesting because, the various positions that employers would take when they had a code red outbreak, they were often assigned a hospital. We know with one home that we had in code red outbreak in Kitchener, the hospital was actually saying to their staff, we're not sending anybody into that nursing home because it's not safe. It's not safe for us to send our workers into that hospital. So we had severe challenges. We had, if you can imagine, when a code red outbreak starts, it starts really quickly, and dozens of staff will be testing positive, dozens of residents will be testing positive, and you're not only struggling to get PPE, but you're also struggling to get people to come to work. People are sick. There is. I know that people would like to say that, they just decided not to come to work. They just abandoned their residence. But people have various reasons for this. They had, maybe they were immune compromised, or they had a family member that was immune compromised. There are stories of people, personal support workers and others in long-term care who their child care provider all of a sudden said, you know what, you work in that nursing home and I'm not looking after your kids anymore. So there was a whole range of things that frontline workers had to face. We challenged employers as much as we could. With one Ottawa Rivera home, we filed complaints under the Occupational Health and Safety Act. And these were related to, again, not only faulty equipment, but no training on equipment, constant short staffing, not the cohorting issue, of course, which was huge, and especially in older homes. If you can imagine a 300-bed nursing home in a COVID outbreak, and they have only 4 housekeepers working. So these were just the realities. We spent 2 days in mediation with arbitrator Stewart on that issue, particularly to that home. And one of the very things that we wanted to get was access to N95s. We knew from our conversations, particularly with the other unions, we were meeting very regularly, but the evidence was telling us, and certainly the number of personal support workers and other long-term care workers contracting COVID, we knew that the required protection was an N95. We made some gains in that mediation. Arbitrator Stewart was not willing to allow unregulated care workers to be able to access an N95 mask by doing what's called a point of care risk assessment. That was very specific in Directive 5 that you needed to be a regulated worker to be able to do that point of care risk assessment. But if anybody's familiar with a nursing home setting, you may have you could have a 300-bed unit with, especially on a night shift or an afternoon shift, with very few regulated workers in the facility at all. So how do you actually get somebody to come in and do, if you're a personal support worker that's got to go into that room, or if you're cleaning that room, and you're concerned, how do you actually find a nurse to come in and do that point of care risk assessment? Because quite frankly, they're all incredibly busy. We went through the summer months with a bit of a downturn, and it felt like we had a bit of a breather, but none of us were naive enough to think that that this was going away and that wasn't coming back, and it wasn't going to be just as horrible. So we worked particularly, again, Sharleen showed that the video that we did, SEIU invited CUPE and ourselves to join in with that, and we certainly were supportive of that. This is a fight that many of us have had for improving long-term care, and particularly we know of the challenges with for-profit sector. But also in the summer, Michael Hurley from CUPE invited our 2 unions to join him in a judicial review of Directive 5. So Directive 5, if people aren't familiar with it, this is the directive that instructs hospitals, long-term care homes, and retirement homes on the use of PPE and who has access to that. Because of the judicial review that we requested, we were invited into a mediation where we were joined by OCHU and ONA, and spent several evenings on Zoom calls from about 9 p.m. till 11 p.m. With various ministry representatives, as well as a mediator who'd been appointed, and finally at the end of that came out with a greatly improved Directive 5, and essentially what that Directive 5 gives our workers the right to, and this is really important because it covers nursing homes, and it also covers workers in retirement homes where we know we've also had some severe outbreaks. But essentially, if their workplace is an outbreak, which is after there's 1 case, if you are within 2 meters of a suspected or a confirmed COVID resident and giving care, that you can access an N95 mask. And so, I'll just give you a bit of how that's playing out a little differently in another Ottawa home that we have right now. It's an extended care home that's an outbreak. We have with 26 residents and 16 staff members. But all of those caregivers are getting access to N95. So when they're caring for a COVID resident, and it's so important not just to protect the staff, but it's also protecting the other residents that they care for. This is, it's a huge success. We hope that the supply, that we know these are issues as well. But fighting for our members and their right to have appropriate PPE has been important, and I've just been really proud to work with all of the unions on that fight. So I'll end my own comments there and pass it back to you, Tim.
Thank you so much, Katha, for those important comments. Just again, folks, if you have questions, if I could direct you to put them into the chat and who you are intending the questions to go to, so when we get to the Q&A, we're running a little behind on time, so I just want to make sure that if you do have questions, we have some time to get to them. I'm going to turn now to our next speaker, who is Michael Hurley. Michael is the president of Ontario Council Hospital Unions, which is the hospital sector in CUPE, which includes long-term care. Michael has been an incredibly creative and strong voice, both for healthcare workers and for patients, and has worked in close partnership with the Ontario Health Coalition for decades. He has led so many initiatives that we could not possibly even begin to name them here. Michael, we're honored you could join us. Yeah, you should be unmuted, and please start your comments.
Thanks so much, Tim, and thank you, everyone. And I think one of the wonderful byproducts of the pandemic has been that the unions have been working very, very closely on these common issues, and I would say that our problems in securing protection are not Ontario problems, they're not Canadian problems or North American problems, they're really international problems. There are Asian jurisdictions particularly which are much more thoughtful and protective of their healthcare workers, but generally speaking, nurses and other healthcare workers around the world are struggling for basic protections and are dying in numbers which are just unconscionable. And to put it in context, in Ontario, where the numbers are actively repressed by the provincial government, I believe, like we experience, maybe you experienced this, that For example, people will be redeployed from a hospital to a nursing home and might contract COVID working in an outbreak there, and their home employer will deny that they could possibly have gotten that virus in that environment. The first cleaner that died in Brampton, public health was on that within 2 or 3 hours to say that he couldn't possibly have contracted coronavirus at work. He must have got it in the community, because of course part of what we're doing here is pretending, all engaged in pretending, that the problem is not as widespread for healthcare workers as it is. But even using the government's numbers, which we believe are kept low, 7,500 of us have caught COVID at work, and using their numbers, 14 have died. And to put that in a worldwide perspective, you know, our rate of infection of about 20% of all cases is much higher than the rest of the world here in Ontario. And it's really high compared to a jurisdiction like China, which had a similarly high rate of healthcare worker casualty early on, but moved to Ebola precautions to protect its workforce, and saw the extent of healthcare worker death and illness really collapse to just around 4%. So we know it's possible, but of course what the Chinese and some of the other Asian countries are doing is they're acknowledging that this virus can be spread through the air outside of aerosolizing procedures. This is something that we fanatically, our government fanatically opposes accepting. And of course, it has enormous implications for us, and it has enormous implications for the people we care for in congregate living settings, which, you know, don't have great ventilation systems and where people are housed too closely together. And as a result, we have a rate of illness and death in the populations we care for, particularly in those settings. And if you look at long-term care, like a heartbreaking level of people who've died, and we would say died who didn't have to. And we would say that if you looked at other countries like, and again, Taiwan or China or Vietnam or Singapore, you would see that it isn't necessary for people to die in these numbers, in these settings. It does require accepting that this virus can be spread in ways which we don't accept it can. This whole thing, as Sharleen and Katha have said, has been you know, just a battle from the very first moment, not just at the provincial level in terms of trying to secure access to the equipment, but also you know, on all the units and in all the facilities where we represent members, struggling to get access to face shields or to impermeable gowns or to N95 respirators. And it points to, you know, something which other studies of healthcare workers in Ontario have highlighted, for example, with respect to violence at work. You know, our members are not valued. The work that we do is not valued. Our lives are not valued. Our safety is not valued. We have limited rights with respect to the right to refuse unsafe work. We have, you know, when we call in the Ministry of Labor to support us, they read stuff strictly. We have a large number of WSIB claims which have been denied through this crisis. So the struggle here will continue. We've made gains on Directive 5 thanks to our close work together, but the struggle to get that equipment out on the units will continue and will be fought out, you know, there. But the great thing I think about this pandemic is that healthcare workers for a long time, you know, have felt that undervaluation. Like, work wasn't valued, people were underpaid, you know, worked in environments without much dignity, with work regimes which were like, you know, on a continual speed up model, and where all the humanity was stripped away to the extent it could be. And one great thing that's come out of this pandemic has been the you know, the sense that healthcare workers have, that the public values the work that we do and our connection to the people that we care for. And that gives me great hope going forward, because we are going to change the way healthcare workers are valued. Monetarily, but as importantly in terms of our health and safety and well-being. And we're going to change, as you know, Sharleen has, and Katha have said, that you know, the conditions under which people are living in long-term care and other congregate living settings, and we're going to do that with public support. So you know, I'll stop there. Thank you very much.
Thank you very much, Michael, for your comments. We'll go now to our last speaker. Our last speaker is Nicole Butt, who is a lawyer and manager of litigations at ONA. She is an expert in arbitration and litigation related to the issues we're talking about today. We're so glad she could be with us. Thank you, Nicole, for joining us. You should be unmuted, and please start your comments.
So I wanted to talk about some of the steps that ONA took fairly early on during the pandemic to address some of the really distressing things that we were hearing were happening. And, you know, you've heard about what was going on, the garbage bags having to be worn, not enough staff. There often were no leaders on site either, and no doctors. And so it was really, really problematic. Workers were getting sick in alarming numbers. We had members who were in the ICU. We had a member who was on a ventilator for 19 days, another who was in the ICU for 13 days, and we did tragically have one member who passed away. And we know that member, before that he got sick, he'd worked 7 nights in a row, and he had been denied access to N95s. So we were extremely worried about the safety of our members and the residents. And at first we did what's been talked about. We contacted the Ministry of Labor, and we thought that perhaps that would be, you know, the solution. We would get the inspectors in to protect the workers. And unfortunately that didn't happen. They were not helpful. They interpreted things in such a way that they thought they were only having to enforce and make sure that the directives were being enforced, but the directives, of course, were very loosely written in some cases. So it would say cohort where possible, or isolate if possible. And so we just weren't finding any help at all from the Ministry of Labor. And there was a question in the chat about why there weren't more walkouts, and that's largely because, at least, you know, ONA's members have a very limited right to refuse work. And so that wasn't really an option. And, you know, if they walked out, there'd be even less staff for the residents. And so it was just a really difficult time. So we made the decision to file for an injunction at the Superior Court. And what we did, we asked a judge to force 4 homes in particular to comply with the directives. And we focused on 4 homes, but easily could have picked another 20 or 30. And not surprisingly, all of them were for-profit, and they were owned, the ones that we focused on there were owned by a smaller chain called Rika. And, you know, at that time, and this was in mid-April, there were 110 residents sick, 54 had passed away, and 7 nurses had also contracted COVID, and it just got worse from there. So we put some affidavits before the judge, and the very day that the application was filed, the judge held a teleconference, and he clearly communicated that he saw this as urgent. The respondents tried to delay the hearing. They wanted several weeks or a month to gather, you know, their ability to respond. And he refused and said, no, you're going to do it over the weekend. And so we had a hearing date 5 days later on the Tuesday. During the hearing, we were asking that nurses be provided with access to PPE, including N95s. And that meant not just following the directive, but making sure that if the nurses judged that they needed to have N95s, that they would be provided with them, that they're the ones that would be making that assessment. And we also asked for orders that they isolate the residents and that they cohort residents, because again, we were hearing from these homes that they were keeping residents in rooms that had 4 residents and separating them with just like a flimsy curtain, which was clearly not going to keep the infections down. The respondents argued that they were compliant, and They argued that we were just trying to access scarce resources for our own members instead of thinking more broadly about the rest of the community. And they argued that they should be determining whether N95s and PPE was necessary because only they were going to be the ones thinking about how to conserve these scarce resources. The Attorney General also intervened, and their position, they sort of provided the context for the directives. They also put forward an expert who clearly said that the directives were based on a concern about supply, and it wasn't based on the precautionary principle, and that, you know, this virus could be, and we think is, airborne, but rather it was concerned about supply. And, you know, if the workers in the nursing homes were using them, then what would happen to the workers elsewhere who also need them? Justice Morgan released his decision 2 days later. So this all happened within the space of a week. And he ordered the residents to comply with the directives and to provide the N95. So it was a huge victory for those 4 homes. And I think one of the most gratifying comments he made was he didn't buy the respondents' argument that ONA was being self-serving and that they were the ones looking out for everyone. He said that it was very ironic that they would argue that. He said one only need read the affidavits of the individual nurses to understand that they spend their working days, in particular during the current emergency situation, sacrificing their personal interests to those of the people under their care. And they're doing it not only for the immediate benefit of their patients, but for the benefit of society at large. To suggest that their quest for masks, protective gear, and cohorting that is crucial to the lives and health of themselves and their patients is a narrow private interest seems to sorely miss the mark. And so he was really admonishing the respondents, who again were all for-profit homes, for trying to paint the nurses as being selfish and out just to get PPE for themselves. Most importantly, he indicated that the final word on whether N95s were required is to be determined by the worker at the point of care and not by the home's management, and that they couldn't control access. Following that, and I know that we're short on time, we appeared before arbitrator Stewart, and he adopted basically the Morgan rationale and applied it to all of the homes that were participating, so over 150 homes. He also, in the Stewart arbitration decision, emphasized that when workers are doing the point of care risk assessment, it's not just whether there's an aerosol generating medical procedure, but they also have to consider the context in which they're working, which includes the fact that many of these residents exhibit behaviors that pose a danger. So there's coughing, there's spitting, and other sort of behaviors through no fault of their own that make it riskier for long-term care residents. So both of these, we were very successful in both. Unfortunately, there's still homes that aren't complying, and as we are going into the second wave, we're finding more and more of them. And so those homes that didn't experience an outbreak the first time around, it's like we're replaying the same story, and the PPE is still being locked up, and we're having to constantly call arbitrator Stewart and try to resolve this. And so I think, to summarize, Michael used the phrase, it was like a battle, and that's exactly what this was, and it continues to be. There's a constant battle, and at the end of the day, we need to keep in mind the safety of the workers. We need to keep in mind the safety of the residents, and really find a way to make it safer for everybody, or else it's just going to be worse. And the for-profit homes really are going to have a lot to answer for at the end of this, I think.
Thank you, Nicole, for that. We're very close to the end of our session, so I would note for those of you who can, that I see Sharleen addressed the question that I had posed earlier about what are some things that people could do now, and you can access your social media, you can access radio programs. They're really important to keep the public narrative going on this, because as also I think Sharleen and Katha and Michael had said, this isn't new. a lot of these concerns. This didn't just come as of COVID-19. Those of us who have been dealing with long-term care and retirement, you know, through the labor movement have been seeing this sort of poor conditions in the industry forever. I've been involved myself through my union for over 17 years with long-term care, and the issues we're talking about with staffing and with respect to supplies and the level of employment, those issues have been going on for 17 years for my employment. So the more we can all work together to keep this in the public narrative and to put pressure on particularly our provincial politicians, the more chance we have. I see that we have MPP Wayne Gates with us, and I'm sure he'll be happy to have me tell everybody, and as I saw Katha said in the comments as well, that Teresa Armstrong's private member bill, the Time to Care, which is now the 4th time it's been introduced, is coming up for second reading later on next week. This is something that we should really push on all of our provincial politicians to support, because every report that's come out recently has highlighted the fact that a 4-hour minimum standard of care is an absolute necessity, and that's one of the ways that we can try to make some positive change. So with that in mind, unfortunately, we're at the end of our session. I want to thank all of our participants for coming in and speaking and so passionately to the work that they've done to try to protect their workers and all workers in the industry and long-term care, the work that will be going on go forward. And the positive note, as Michael and others highlighted, is that there is now a narrative to make some real positive change, to finally see some real constructive improvements in the long-term care industry in this province. And that's something that you folks should all be proud of the work you've done. We should all continue, because as Nicole just said, it's not like this fight is over. If anything, we're just right in the beginning of it. So let's all keep moving forward and try to see improvement. And thank you all so much for participating in this panel. Thank you.